Good afternoon, Dr. Mohler. Thank you very much for taking the time to join us.
My pleasure.
We had asked you, I think, prior to the program, to talk to us a little bit about some of the evolving issues in the diagnosis of prostate cancer, particularly in the most recent update to the NCCN Guidelines. We've obviously noted that you've included information now about the potentially appropriate use of multi-parametric MRI in diagnosis and also in active surveillance. And you've mentioned also the issue of the multiple new genetic and genomic tests that are coming to market. But clearly for the patient community, additional guidance about when people feel these are more or less appropriate forms of testing would be extremely useful. So I'd be interested in you talking a bit about some of the most recent and important updates to the NCCN Guidelines, but also focusing on those two particular issues, if you would care to do that for a little while.
Yeah, I'd be happy to begin our discussion that way. It's been very interesting for me to watch my colleague Peter Carroll over the last 2 years improve the prostate cancer early detection guidelines. I think they've been made much simpler and therefore much more user-friendly, and I urge all your listeners to pay careful attention to the simplification, which is largely encompassed in the second page of the guideline, PROS D2. We're very particular about the use of PSA for early detection and for guiding treatment because we discovered it here at Roswell Park. I still think that PSA is best used not as a snapshot. In other words, not just paying attention to what a value is on a given day, but it's most valuable when it's used in conjunction with prior values so that you're able to look at what we call PSA Kinetics, whether you do that by calculating a PSA velocity or a PSA doubling time. This additional information provided by PSA then makes many of the nomograms much more useful and can personalize the use of PSA to your particular situation, especially when you combine what your PSA kinetics are with your own age and health and other parameters such as your digital rectal exam, your family history, etc., etc. So now that brings us to how to use a PSA to prevent a man from suffering from PSA anxiety. And I frequently say that should perhaps be a new psychiatric definition because so many men are so focused upon their PSA, both men who don't have prostate cancer and as well, and more appropriately so, those men who have prostate cancer, where PSA is far more valuable for monitoring their disease. But I think what the Sloan Kettering group has shown us is that if you are fortunate enough to have a low PSA, you don't have to get anxious every year, or in some cases, some urologists even use a PSA every 6 months, which there's absolutely no data that they should be performed that frequently. But if your PSA is less than 1 and you're less than 50 years old, you are in a very, very good place. And you probably don't need another PSA until you turn 50 years old. Now, if you're higher risk group, such as you're African American, you have a first-degree relative with prostate cancer, you probably want to get a PSA a little more often, maybe every year or two. The modeling suggests that every 2 years is optimal. And then when you get to that 50th birthday, the current NCCN guidelines recommend PSA every 1 to 2 years. And again, you can tailor it based upon your risk factors. And as long as your PSA stays less than 3, you're in a pretty good group. And then you should begin to think as you get older about whether it's worth the risk of having a prostate cancer detected that you didn't want to have detected. In other words, that you're not going to live long enough to suffer a death from prostate cancer, and hence why know about it, and more importantly, why suffer the consequences of side effects of treatment when you probably didn't need the treatment in the first place. So we're encouraging men when they reach a physiologic age of 70, notice I didn't say chronologic age, but a physiologic age of 70, they probably can forego any additional PSAs. If we did everything I just mentioned, if we complied with the NCCN guidelines, we would see a tremendous reduction in the costs, both financial and anxiety-wise, associated with overuse of PSA, which leads to overdetection of prostate cancer. So with that as a baseline, let me now talk about the use of multi-parametric MRI. And this is a 3-part study which then requires a rather sophisticated computer analysis of the images to calculate some numerical data that allows radiologists to assign low, intermediate, or high risk of a lesion being an aggressive prostate cancer. We're learning a lot about 3-parameter MRI or multi-parametric MRI, and it appears to have an advantage that it rarely sees the little well-differentiated cancers that I call autopsy-type cancer that all men get as they age. Your chance of having that type of cancer is about the same as your age in percent. So I'm 61 years old. I have a 61% chance of talking to you today having an indolent prostate cancer in my prostate. Now, I don't want to be biopsied to find that out, and it appears an advantage of the multi-parameter MRI is it doesn't see this type of cancer, and it may see the aggressive ones. So right now, when a man has an elevated PSA and has a negative routine biopsy, the NCCN guidelines suggest that a multi-parameter MRI may be appropriate to make sure you're not missing an aggressive prostate cancer. In addition, MRI might be useful in treatment planning for men who are concerned whether nerve preservation is appropriate or not when they have a bulky prostate cancer or a prostate cancer that is poorly differentiated. Then the last way to personalize your prostate cancer situation is to take advantage of the new molecular tests that are available. And there are many of them, and that's confusing many men and many of us urologists as well. There are 3 about which the most is known at the present time. These are the assays from Polaris Corporation, the Oncotype DX prostate cancer assay, and the Decipher assay. And each of these takes advantage of the expression of genes that are by the prostate cancer that can be used in most cases to guess at the growth rate and hence the aggressiveness of the prostate cancer. So some of the tests recognize an aggressive cancer, others recognize the absence of an aggressive cancer. And so some men who should be undergoing active surveillance of a low-risk cancer might find themselves more able to live with the anxiety of watching something called cancer if they knew that a molecular test was consistent with a low growth rate. Other men faced with an elevated PSA might like to take advantage of newer ways of analyzing PSA or of different tests that can be performed on the urine or the serum that might help them to decide whether they should have a biopsy or not, and that and if they're fearful of missing an aggressive cancer. So these new molecular tests are coming along at a very rapid rate. They go through a very different approval process at the FDA. And so, as I wrote in the NCCN treatment guideline, I'm a little concerned that we're going to have to depend on the marketplace to properly position them as to whether they're valuable to help men with their decision making or not. And in the meantime, we don't have clear evidence that they will help with decision making. That will need to be accumulated. And so many of the insurance companies are declining to pay for these, and the common denominator to many of these tests is they're quite expensive.
So perhaps I could just ask a couple of questions, Dr. Mohler, for clarification. My understanding is that the MPMRI test is available at a relatively limited number of centers at the present time and does require some very sophisticated uropathological skills in order to interpret the imagery and this sort of thing. So I'm curious how fast you think that technology is starting to spread out into the broader community. And the other question I was going to ask you was very specifically about the PCA3 test, where we're seeing some fairly some differences of opinion about the value of the test.
All right, so I always have trouble remembering more than one question at a time, but I'll try and handle this. So let's take the multi-parameter MRI first. This is a technologically demanding test that requires basically 3 MRIs in one. It has to be done on a 3T magnet, and then it requires a rather sophisticated analysis of the images. So that's sophisticated software. But most importantly, you have to have an experienced uroradiologist who's very good at interpreting these. So that it's not enough for a man to go and say, do you have a 3T magnet, or are you capable of analyzing all 3 parameters of a complex MRI? But you also have to know, do they have a radiologist or radiologist highly skilled in this area? So we're very concerned that the results that are being published now, largely as single institution experiences, are going to be very difficult to disseminate through community practices and even smaller academic settings that don't see as many patients with prostate cancer. So this is another example of where it's not just the technology, it's the people that go with the technology that are going to make this valuable. And if this can't be disseminated, it's going to have to stay in centers of excellence, and then patients are going to be inconvenienced because to realize the value of a 3-parameter MRI in these particular situations I mentioned, they're going to have to travel. The other thing I should mention about 3-parameter MRI is if you have one shortly after a prostate biopsy, it will be uninterpretable because of the bleeding and inflammation that results from the biopsy. So I'm already seeing far too many patients that have a diagnosis of prostate cancer and then the next week have a 3-parameter MRI and are told that their cancer is really advanced or they can't have their nerves spared or whatever, and all the radiologist is doing is confusing the bleeding and inflammation that results from prostate biopsy with an aggressive cancer. With regard to the PCA3, this test was developed by a good friend of mine, so I don't allow that to bias me. All of these tests that are used to help a man decide what to do when the PSA is between 2.5 and 10, I do not believe have been critically enough evaluated in the context of Psa Kinetics. it's very important that these tests give additive information above and beyond Psa Kinetics. But what I just said is very controversial. It's kind of my personal opinion, and I hate to do this to patients out there, but this is an area where more research is necessary. It's very important. I still believe personally that I would rather see PSA values measured once a year for several years than any test of PSA derivatives or alternatives to the PSA test at this time based on what I know. But this is not my particular area of expertise. So I wouldn't take what I said to the bank.